Thank you, and thanks to the organizers for inviting me to participate. So I'm going to talk about primary chemotherapy and locally advanced cervical cancer in 2025. Here are my disclosures. So just to remind everybody why we started down this road of looking again at primary chemotherapy, if we cast our minds back to the first decade of this century, you'll note that 5-year overall survival rates with chemoradiation were 54 to 65%, depending on which analysis you looked at. Clearly, a lot of women were still relapsing with this disease and subsequently dying. So there was a clear unmet need. We started to look at, if we think about, first of all, neoadjuvant chemotherapy, as it used to be called in the past, and the multitude of trials that were conducted in the 80s and the 90s. And these were generally followed at that time by radical radiotherapy or radiotherapy alone. They were very heterogeneous trials, generally quite small, and the results were conflicting. A meta-analysis published in 2003 of 18 trials involving over 2,000 patients gave us some pause to think about this subject again. So what they found when they analyzed the...
Dear Professor Lichtnecker, dear colleagues, first of all, I would like to thank for the opportunity to give the perspective of a radiation oncologist in the treatment of locally advanced cervical cancer. I have no disclosures in this topic. And as you can imagine, of course, you cannot speak about this topic without mentioning the trial by Domenica Lorusso that was mentioned before, also by my colleague, Dr. Armbrust. And I had the pleasure of hearing Professor Lorusso giving a talk at the ESTRO convention, the European Society of Radiation Oncologists, a few days ago in Vienna. And I don't want to go too deep into the details. The session was called, the results of the study were presented in this debate session entitled "The Best Treatment for T2N1 Cervical Cancer Is." So you see the focus was on neoadjuvant treatment and on the chemo-immune combination treatment. And first of all, I would like to state that regarding the Keynote A18 study, it was a study that was conducted very fast. It was recruited during the high season of the COVID pandemic between June 2020 and December.
Thank you, Nadim, for the introduction, Professor Lichtenegger and audience. My talk is about the primary surgery for locally advanced cervical cancer, and I'm aware that the most guidelines worldwide will say no surgery for this group of patients, but we have to admit first that we don't have a clear definition what is locally advanced cervical cancer. Most of us will agree with 2B to 3A, but even in many guidelines, the 1B3, tumor more than 4 centimeter, and 2A2 will be included in locally advanced cervical cancer. And accordingly, we don't have consistently an agreement about the therapy for locally advanced cervical cancer. And you will be able to see that many centers in South Asia and even in South America will advise to do surgery in this group. And the VICO report from 2006 included more than 15,000 patients, 6,000 patients of them received primary surgery for cervical cancer. We will be able to see that the primary surgery can downstage 20 to 40% of all